I would like to start by introducing our first speaker. Dr. Ray Hachem is now a full professor in infectious disease. He is a part of the Department of Infectious Disease, Infection Control, and Employee Health. He has been the Director of Infectious Disease Trainee and Observership Program in our department. And he has more than 100 publications in the field of invasive fungal infections pertaining to the cancer patient population. He will be speaking to us tonight on this important subject of changing epidemiology and outcome of invasive candidiasis in cancer patients. Without further ado, Dr. Hachem, please come forward to the podium.
Well, thank you for this great introduction, and welcome everybody's here. Everybody's hearing me? Okay, well. So thank you for taking the time and coming to this evening, and I know everybody's been busy. So I'm going to, in the next 30 minutes, just update you on the challenge we're facing in invasive candidiasis, and the other two speakers will be dealing with invasive mold infection, aspergillus, and others. So needless to say, invasive candidiasis is still considered one of the major invasive fungal infection, and according to the CDC and also to NHS, that they are the National Health Safety Network, Candida species are ranked 5th among the hospital-acquired pathogen, and also rank 4th among the bloodstream infection. So this is something, even with all the antifungal we have, the rate of invasive candidiasis is still high and remain due to some of delay of initiation of antifungal therapy and not knowing the early diagnosis. So those are important points we have to face in our future, to focus on that and change the epidemiology of invasive candidiasis. As we know, the blood cultures usually take long and is delayed, and only 50% of the time positive. So this is another point we have to focus on, and hopefully can be changing this. And so certainly faster and more sensitive and non-invasive approach will be the way to go. So if you look at the epidemiology of the candidiasis being changed, because previously we used to see, as you see in the slide, Candida albicans is the major contributor for the invasive candidiasis, but now Candida albicans start going down, and this study done from MD Anderson with Dr. Cantonianis group, and you can see the albican going down, but the non-albican taken over. And that's the reason you really look into the mortality is higher, because it's range between 30 to 60% due to those non-albican most likely resistant to a lot of agent we have. So this is very important to know the epidemiology. And another aspect, we need to know our hospital epidemiology. Like not all patients are the same, and not all patients have the high risk of specific candida. If you look here into hematologic malignancy patients, where you see the highest Candida glabrata, it's the highest among those patient population, and Candida krusei in hematologic malignancy. Where you look into solid tumor, you see the rate of Candida glabrata a lot less, and especially krusei less, and then you have the highest of Candida albicans. So this is important also to know the epidemiology of your institution, and of your patient host factor is very crucial too. So this is the distribution of the Candida. If you look overall, Candida albicans, only 36% of the overall contributor of all Candida, and non-albican contribute to the rest of the chart. So this is very important for us to know, so we can really focus our target therapy. This is another study from the therapeutic and clinical risk management just appeared in 2014, and also look into the distribution of the Candida in North America. And you can see here, the albicans ranking here, and all non-albican similar to what's happening in that other slide I show you. Even if you look into Asia Pacific region, also the albican is going down. If you could see here, 35%, 164%, and this is non-albican all over distribution in different country. And then also another one looking at Latin America, and you can see different in Argentina and Brazil and Chile, all different, but all over the Candida albicans decreasing like 27% here, and you can see non-albican, it's in the high ranking. So it's not only specific to United States, it's all over the country and all over the world. You see the increase of non-albican compared to the albicans. What are the risk factors? This is very important for us to understand the risk factors that contributed to invasive candidiasis. All of those listed here, a major contributor from central venous catheter, systemic antibiotic, major surgery. Immunosuppression is a big major contributor in our center. And colonization with Candida species also another factor, or total parenteral nutrition. So those are important points to really understand the risk factor of the Candida so we can do something. There's also another issue, prior antibiotic therapy, also another risk factor for acquiring Candida glabrata or Candida krusei, and those are the major resistant Candida among the organism we know. So as far as this study being published, and you can tell that independent risk factor as piperacillin, tazobactam, those antibiotic, vancomycin, but in this specific study, fluconazole was not really an independent risk factor for Candida glabrata and Candida krusei. Some other study show that fluconazole may be a risk factor, but not in this one. So what about Candida colonization? Is it a risk factor for invasive candidiasis? This actually, a large study, prospective, almost covers 6,000 non-neutropenic critically ill patients. It showed that colonization with Candida species was an independent risk factor for invasive candidiasis. And that was really, and the risk was highest in urine colonization compared to the others. And also, if you were colonized more than 2 sites, or heavy colonization, even 1 site, it was significantly considered as an independent risk factor for invasive candidiasis. And this is just up here recently in the Journal of Clinical Microbiology this month. So what other risk factor we can look? Really, being in the ICU for a long time, certainly this is a major contributor for increased patient incidence of invasive candidiasis. More than 7 days, the risk will start climbing pretty high, and it's really incredibly connected with stay in the ICU. So as far as the ICU, the epidemiology is very important to know, and we need to know better diagnostic and need practical rule to assess risk in the ICU. And then we have a lot of approach, prophylaxis, preemptive, and traditional treatment to tackle with our invasive Candida in the ICU. So is the mortality, are we doing better? Well, I mean, with all the therapy I was mentioning before, the mortality still range between 40 to, to 85, 58%, depend on the Candida. The non-albican is certainly have a higher mortality than the albican. And then really it's the optimal therapy, how early you start, how better you can do. And not all Candida are similar. If you see here, the Candida glabrata have the highest, and Candida krusei the highest mortality if you compare the other Candida albicans or other Candida. So certainly it's important to know what Candida you're dealing with and how early to start therapy. And this study really confirmed the issue if early treatment with low mortality, delayed therapy, even with 24-hour, you double your mortality and you will be losing your patient. And also the dosing is very important how to do in order to get better response. So what we're gonna do as far as early diagnosis and why is very important. Because most likely what we do with the culture, we get our patient at this stage here. Culture histopathology, and at this time you have your mortality is high. So where we target in our approach the new diagnostic tool with biomarker, we need to diagnose our patient early here so we can treat them and we can have better outcome with our patient population. So what do we have? Like I said, the traditional is negative 50%, the delay in the technique, and the biopsy is not possible, it's not feasible on every patient, especially with patient with profound thrombocytopenic, you cannot do biopsy. So what we need to do is we need to move into molecular diagnostic, and you can see sensitivity of beta-glucan, which detect really well the candida in the system, 90% sensitivity range to 100%, and also specificity from 100 to 63%, depend in what patient you're using and what diagnostic tool and how you're using your data. So as far as the beta-glucan, really to be positive, right now we always use more than 80 milligram per ml, and the sensitivity of this 78%, 98% of the studies done by in the clinical infectious disease. And this is a study I published in Clinical Microbiology 2008. Also, the sensitivity was beta-glucan 83%, specificity 90%. So this is a good tool to detect really candida early on before your blood culture coming in. And then what other strategy for the prevention? Certainly you need to use hand hygiene, you need to use your infection control measure, and this is very important to decrease the candida in any place. And especially you need to control your antimicrobial use, because the extensive use, you have to induce more resistant and more actually candida in the system. So what about the FDA approval medication? Certainly the echinocandin, caspofungin, micafungin, and irofungin, they all pretty similar in their efficacy, but they are a little bit different as far as FDA approval. And the only one you can make attention to here, like for neutropenia, caspofungin has been approved. As far as prophylaxis in the hematologic malignancy, stem cell, micafungin. And then for aspergillus, the only one is being approved actually by the FDA is caspofungin. It doesn't mean that caspofungin as a monotherapy will be the use, but it have activity and being approved by the FDA for the invasive aspergillosis. So what about if you look at the MIC? They're all pretty similar. Actually, you don't see much difference in MIC. And irofungin, caspofungin, and micafungin are pretty similar. There's not much difference in there. But as far as really a treatment for invasive candidiasis, those are the study you can see is done comparing caspofungin with actually amphotericin B, and then you can see as far as efficacy, pretty similar, not much difference, but where the difference was in nephrotoxicity with amphotericin B was significantly worse, certainly, than caspofungin, and then that's where the point of issues with caspofungin when you compare it to amphotericin B. What about caspofungin to micafungin? There was no difference in efficacy, and also as far as safety were similar. And this is study in the New England Journal of Medicine, also comparing anidrofungin to fluconazole. Certainly anidrofungin was superior a little bit. It's not like significantly, but it's a little bit better than fluconazole. And this is exactly where the major advantage of echinocandin for invasive candidiasis. So this is another study looking into also micafungin for the treatment of a proven and expected invasive candidiasis. And this is in children and also neonate and overall prospective study. And this is done in October 2010 to March 2012. And they look into what the efficacy of really micafungin in this different group. And you can see here different type of proven invasive candidiasis, 66% overall favorable response. Suspected, it was 69%. But look in here, less than 18 years old, 76% response, favorable response, and patient with more than 18 years old, 63% response. Candida albicans 68, non-albicans 64. So it's pretty reasonable activity with micafungin in this different patient population. What about if you look into survival regarding to the catheter? If you have a line, certainly if you remove the line, you have better survival than keeping the line in. There's no question about this. And also if you have resistant patient with fluconazole, the survival is less than those ones susceptible to fluconazole. So it's interesting to know. What about the IDSA guideline? IDSA guideline, it really emphasized an infection control line, also very important to remove the line whenever you have line-related candidemia. It's not any patient who have line, you remove the line, it's respective. You have to confirm you have line-related candidemia. It will make a difference to remove the line, certainly. So what about non-neutropenic patient? So for non-neutropenic patient, when you identify you don't know what the organism is, you could use fluconazole in those less critically ill patients, but echinocandin is still recommended in those moderately severe ill patients in the ICU. And also when you have sepsis, especially if you have Candida glabrata, you have to use echinocandin pending the susceptibility testing. And if you have Candida parapsilosis, you use the fluconazole. Those for non-neutropenic. In the neutropenic situation, they recommended really, as far as an A1, the echinocandin is the way to go. Either caspofungin 70, you go down to 50, or mica 100, or anidrofungin 200. So if a patient also critically ill, no recent azole exposure, then you could go, on those non-critically ill, you could use fluconazole if you don't have any exposure to the azole before, and that will get category B3. Voriconazole also recommended to be used, also category B3, and also for infection was due to Candida glabrata or Candida krusei. In that setting, echinocandin is the drug of choice in that setting, or you could use voriconazole or liposomal amphotericin B for those issues. But when you have a Candida parapsilosis, they recommend to use fluconazole or liposomal amphotericin B in situation like this. So those overall, if you, diagram, if you have a yeast in culture, then you have to divide your patient into non-immunocompromised to immunocompromised. The reason of that, because in immunocompromised, you have to start with lipid amphotericin B, and before you do, and then if you know it's an endemic mycosis, you continue this way. If you have Candida species, in most of the situation, you go down and you start echinocandin or lipid amphotericin B. But in the situation when you have hemodynamically stable patients, you don't have neutropenia, you don't have high Candida glabrata or Candida krusei, you could use fluconazole in that setting. And then you look at the response, and if it responds, it will be fine. You complete 14 days. If it's not response, you switch to the other agent that you have not used in that setting. So what about the issue with the question right now? A lot of people asking, is echinocandin, is the start with any Candida? I don't know the answer. A lot of people do different ways. And is antifungal activity in the biofilm associated with Candida without removing the line or not? So those are the questions facing us. What is the potential echinocandin resistant in Candida? So I will tackle those quickly. As far as biofilm, really this study show that caspofungin, it works very well in the biofilm if you have high dose and enough to eradicate the bug in the biofilm. But fluconazole doesn't do anything regardless what you do dosing. Amphotericin B is a little bit okay, but not much. You have to have higher dose too. And so this is very important study to show us but another point I would like to mention, the extensive use of any drugs, you're gonna have emergence of resistance as you see here. This is extensive use of fluconazole and echinocandin. It led to increased resistance of echinocandin to the Candida, and you can see the majority of the gene, the FKS1 gene, that causes resistance, and there's different of one of them, FKS1, FKS2, and then you have a different SC64. So all of those resistant Candida, Candida glabrata or Candida albicans or any other Candida. So for echinocandin, this is the major gene mutation. And this is from MD Anderson, also a slide from Dr. Cantonianis, and he really showed that not only Candida tropicalis was actually at MD Anderson causing this major echinocandin resistance with MIC more than 2 microgram per ml, even went to up to 8, and this was FKS1 mutation hotspot, and that's what the major one. But all those patients, they receive echinocandins more than 20 days. So overall, a lot of studies shown more than 30 days using echinocandin. Sometimes you expose your patient to some of the resistant, and most of those patients have catheter infection, and most of them have antibiotic, not drug resistant. So let me just get back into the last slide. So as far another actually resistant candida, the one I showed to you, another study from MD Anderson just recently appeared, and it looked into the resistance of actually to Candida glabrata with echinocandin. And this is published by Dr. Cantonianis and his group, and you can see in this one the resistance all over, I mean the major risk factor of the Candida glabrata resistant was hematologic malignancy patient. You have a lot of neutropenia, total voluntary nutrition. All of those risk factors were contributing to emergence of resistance. And you can tell here is according to the MIC, where the mortality, the higher MIC, you have the better survival, and then with the MIC of 2 and more, you have higher mortality was corresponding to the echinocandin study. So also, there's also emergence of azole resistant, and you can see here Candida albicans, 98% of fluconazole, itraconazole, but Candida glabrata only 40% and 8%. When you go to Candida krusei, there's no susceptibility to azole, so it's just really. So in my summary, invasive candidiasis is still common and with high mortality and morbidity, and making the diagnosis is the most important for our early effective therapy to improve the outcome of our patients. And we have to make attention to those Candida glabrata, Candida krusei in some setting of high-risk patient, to those Candida to target therapy accordingly. So echinocandin may be the first line for really sick and neutropenic cancer patients. Thank you for your attention.